Okay, and like I mentioned, we'll be reviewing medical emergencies today, and we will be starting with head injury. So again, head injury would be any trauma to the scalp or the skull or the brain. It could be either a closed or open or maybe a penetrating injury. And when head injury results in brain damage, you're going to see two things with your clients. They're going to assume either of two types of posturing. Posturing indicates that there's deterioration in the client's neurological status. So let's talk about those postures. So we can look at the image on our screen. Okay, so this would be the corticate rigidity or the corticate posturing. Remember, we said posturing tells you there is a deterioration in the client's neurological status, especially when there is head injury. Again, with the corticate posturing or rigidity, it is an abnormal posture in which the person is stiff. You can see that their arms are bent. So they have bent arms, their fist is clenched or flexed, and their legs are usually straight. And this type of posturing is a sign of severe damage in the brain, problems with cervical spinal tract or the cerebral hemisphere. Again, you can also see the cerebrate posturing or the cerebrate rigidity. It's also an abnormal posture that involves the arms and the legs being held straight out. So you can see how the arms and the leg are kind of extended with the toes pointing downwards. So again, the muscles are going to be tightened. And again, this tells you there's been severe damage to the brain, especially when there's problems within the midbrain or the pons. So one way I used to remember this, remember, the client will go from the corticate. If it's getting worse, he's going to go to the cerebrate posturing. So again, one way I remember this is the C's. We have two C's in the corticate. So that tells me the arms are like C's moved in towards the spinal cord. Remember, the spinal cord is at the midline. So again, when the arms interlock like a C, remember we said the arms will be flexed. So you're going to see the arms locked like C's. And again, you want to remember that with the C's in the corticate. And we said, usually you will see this with problems with the cervical spinal tract or the cerebral hemisphere. With the cerebrate posturing, you can see we have like 4 E's here. So that tells me extensor. So the E reminds me that it's going to be extension of the arms. So the arms are like E's. So you can see how they form an E here, and they are pointing. They are extended, the arms and the legs are extended. So again, the E reminds me of that with the cerebrate posturing, there is extension of the arms or the limbs. Again, we said this is usually seen when you have problems with the midbrain and the pons. So again, progression from the corticate to the cerebrate posturing usually indicates worsening neurological function. Again, you need to remember that for the NCLEX. When your patient is going from having the arms in a C, the arms and the legs in a C, which is the corticate, and it progresses to extending them out, that tells you there's deteriorating neurological function, and you want to notify the primary healthcare provider. So again, because of time, we're going to take your questions after the class. So if you have any questions, you can just write them down so that we don't have to keep breaking. And after the class, we can run through all of the questions. So again, skull fracture would be one type of a head injury. Here you're going to see break in the skull bone, maybe as a result to a blow to the head, a blow that's enough to break the bone. So again, with basilar skull fracture, what do we see? With basilar skull fracture, basilar skull fracture, what are you going to see? There's going to be headache. Obviously, there's going to be that headache and pain. And you also see what we call raccoon eyes. So that's your raccoon eyes here. The client is going to have raccoon eyes. So this will be like bruises around both eyes. We refer to them as your raccoon eyes. There'll be CSF rhinorrhea. So that's your CSF. So you see this free discharge of thin nasal mucous fluid or cerebrospinal fluid from the nose. You would also see the same. So this time around, it will be referred to as CSF autoria. So that will be discharge from the ear. We would also see battle sign. So this is what we call our battle sign. So when you see this bruise behind the ear, it tells you there's a fracture at the bottom of the skull. It's a medical emergency. So you want to take note of that in your client with a basilar skull fracture. What else do we see? So we're going to see battle signs. You can also see what we call hemotympanum. So hemo there tells me blooded. So almost like the tympanic membrane is kind of blooded out. So that tells me there's blood in the middle ear space. So the tympanic membrane is also called your eardrum. So you're going to see, so this is what a normal tympanic membrane should look like. And this is what you will see when your client has a basilar skull fracture. There are other signs you would see in this client. They will feel drowsy. They would have loss of speech, or their speech is slurred. They could also have difficulty swallowing, loss of imbalance. In terms of diagnosis, remember we said with a basal skull fracture, it can cause cerebrospinal fluid to leak from either of the ears or the nose. And this will result in the classic halo sign or the double ring sign. And this sign appears when CSF mixes with blood on an absorbent surface, such as a paper or a bed sheet, and then it creates this double ring pattern. So again, we said you're going to see this halo sign or the double ring sign, and we said it appears when cerebrospinal fluid mixes with blood on a paper or maybe on a bed sheet. So you're going to see this halo sign or double ring sign. Again, this is a classic sign to test whether drainage from the ears or the nose contain cerebrospinal fluid. So you want to carry that out. You want to look out for that in your patient with a skull fracture. We can also carry out X-rays, CTs, and MRI just to confirm that diagnosis. What's our plan for our clients with head injury? Obviously, we need to monitor levels of consciousness, careful intake and output. So again, you want to check vital signs. Look at the pupil size, look at their shapes, look at the quality. Are the both pupils equal? Are they reactive to light? Remember, a head injury can cause the pupils to become bigger than normal, or they can have two different sizes. So you want to look out for that. Check the nose and the ears for CSF leakage. We also want to carry out neurological assessments. So we're evaluating thinking in this patient, we're evaluating motor function, sensory function, their eye movement, their reflexes. We want to determine if the nervous system has been impaired. Again, you want to remember that the level of consciousness is a primary indicator of neurological status. You're going to see this a lot on the NCLEX. You must remember that your client's levels of consciousness is a primary indicator of neurological status. So an alteration in the level of consciousness would occur before any other changes in neurological signs or vital signs. You know, vital sign changes can occur later, but you're going to see those early indicators, those early changes in levels of consciousness to tell you that there's impairment with the client's neurological status. So again, assess the client's behavior to determine their levels of consciousness. Are they confused? Look out for delirium. Look out for unconsciousness. Look out for stupor or coma. So you want to look out for your client's levels of consciousness. Again, we said those are your early indicators of your client's neurological status. Again, we also want to initiate seizure precautions. Remember, this client has had a head injury. So again, they are prone to seizures. So how can we initiate seizure precautions? You want to place the patient's bed in the lowest positions. You want to put the side rails up or want to pat them. If possible, we can even place a mattress on the floor. You want to make sure your oxygen and your suction equipment are available at the patient's bedside if we need to clear the airway. So those are basic. You can place the client in the side lying position. So there are some seizure precautions we'll need to take. We can also give prophylactic anticonvulsants like our topiramate, your gabapentin, even our levetiracetam. So we can give all of these. These are your anticonvulsants. Again, you want to elevate the head of the bed. You will see this on the NCLEX. While we're elevating the head of the bed, that's going to help to decrease intracranial pressure. So again, you always want to think about positioning on the NCLEX. Don't memorize your positioning. Rather ask yourself, why am I putting this patient in this position? what would be the outcome? Is that what I intend to achieve? Again, when I see my client with a head injury, I know that if I elevate the head of the bed to 30 degrees, it's going to help to decrease intracranial pressure. What else can we do for these clients? We can administer glucocorticoids. What are examples of our glucocorticoids, like your dexamethasone? So that's also going to help. This is also going to help to manage and that increase intracranial pressure and that cerebral edema. So we can give our dexamethasone, we can give mannitol, we can give furosemide, like we said. These medications are going to help to manage that increased intracranial pressure and that cerebral edema. We also want to initiate hypothermia in this client, because when we try to lower the core body temperature, it's going to help to decrease metabolic demands and it's going to improve the client's chances of survival. We also want to regulate hydration according to our intake and output. Again, you want to minimize procedures. You want to carry out minimal procedures, those suctioning, turning, positionings. And we want to prevent complications of immobility. What are those complications of immobility that we need to know for the NCLEX? If your client is immobile, he's prone to developing pressure ulcers. He's prone to developing deep vein thrombosis. He's prone to developing pneumonia, urinary tract infection. So again, we need to look out for those and we need to prevent those complications of immobility. We already talked about increased intracranial pressure. So let's break it down further. Again, what can cause the pressure within the brain to increase? It could be as a result of cerebral edema or a hemorrhage or a space-occupying lesion. These can cause growing pressures inside the skull. And the pressure also further injures the brain or the spinal cord. So again, when you assess a client with increased intracranial pressure, remember that altered levels of consciousness is often the earliest sign. We already talked about this. Look out for those altered levels of consciousness because it's often the earliest sign. Again, the level of consciousness is a primary indicator of neurological status. An alteration in the levels of consciousness would occur before any other changes in neurological signs or vital signs. Again, we said vital sign changes can occur later. So you're looking out for confusion in this client. You're looking out for restlessness. These are early signs. So again, assess the client's behavior to determine their levels of consciousness. Is there confusion, restlessness? Are they unconscious? Look out for stupor or coma. Also look out for pupillary changes. So those are also early signs you would see with increased intracranial pressure. Look out for pupillary changes. You know, the oval-shaped pupil will become further dilated and would eventually become non-reactive to light in the presence of increased intracranial pressure. So look out for those pupillary changes. Are the pupils dilated? Are they non-reactive to light? That tells you your client has increased intracranial pressure. Again, we said those vital sign changes can occur later. So those are our late changes. You're going to see increased blood pressure. You're going to see decreased pulse. Again, we said these are late changes. You would even see bradycardia in your clients. Those are late changes that you would see. So be alert for those increased blood pressure, so hypertension, bradypnea. So you notice that their breathing becomes abnormally slow. You also see bradycardia. So these are very late signs. And they are also called our Cushing's triad. So again, look out for Cushing's triad. One way I remember it is hyper, brady, brady. So those are your Cushing triads. With increased intracranial pressure, we said you're going to see increase in blood pressure, a decrease in pulse, and a decrease in respiration. So you want to take note of that on the NCLEX. With increased intracranial pressure, the BP is going to be going up, while the pulse and respiration will be going the other way. So look out for that. Hyper, brady, brady. So hyper for the hypertension, bradycardia for the decreased pulse, bradypnea for the decreased breathing. So hyper, brady, brady. That's one way to remember that. So again, you also want to be alert to widening pulse pressure. For example, we check the client's blood pressure and it's 120/80. So what's your pulse pressure? It's all about doing the maths. you subtract the bottom number from the top number. So if the blood pressure is 120/80, our pulse pressure will be 120 minus 8. So that should be about 40. But if we come back again and we notice that the blood pressure now is 140/80, and you do the maths, the pulse pressure has now become 60. So that's what we refer to as widening pulse pressure. So look out for that on the NCLEX, on your patient with an increase in intracranial pressure. Be alert for that widening pulse pressure. Again, as part of your assessment, you can assess your patient using the Glasgow Coma scale. Again, you want to remember eye opening is 4 points. Verbal response will be 5 points. Motor response will be 6 points. Well, I use glasses, so that's how I remember that eye opening has 4 points, because anybody that uses glasses, they say you have 4 eyes. So eye opening, 4 points, 4 eyes. Again, you can't have a score of 0 on the Glasgow Coma scale. So you want to remember that there's a score for nothing. So all of the none has a score of 1. So if he opens his eye to pressure, he has a score of 2. If he opens his eye to sound, he has a score of 3. If he opens his eye spontaneously, he has a score of 4. With motor response, well, I have a V6 engine. So again, that's how I remember that motor response has a score of 6, because I know that my motor has a V6 engine, a kind of 6. So I use it to remember the 6 there. So again, that's how you can pause the, I'll share the video subsequently. You can pause it and go through the Glasgow Coma scale. But again, what you need to remember for the NCLEX is a score of 3 to 8 means your patient is not doing well. We are thinking about managing this patient's airway, supporting this patient oxygenation and ventilation. We can look out for the scores of, if your patient has a score between 3 to 8, then that indicates a severe head trauma. Whereas if he has a score of 15, it tells you your client is alert and oriented. So again, what are complications that can arise from increased intracranial pressure? One of them would be cerebral hypoxia. There could also be decreased cerebral perfusion as a result of that increased intracranial pressure. And we could also see herniation. So this occurs when brain tissue, blood, cerebrospinal fluid, when all of these shift from their normal position inside the skull. And how do you know that this shift has happened? How do you know these contents have herniated? You're going to see it by pupillary constriction in your patient. So look at the pupils, especially in the presence of head injury, and that could tell you there's brain herniation when the pupils are constricted. What's our plan for our clients? We want to monitor vital signs hourly. So be alert for those increased systolic blood pressure, the widening pulse pressure, the bradycardia. Remember, those are our Cushing's triad. We said hyper, brady. So hypertension, bradycardia, bradypnea. So when you monitor the vital signs, you are looking out for these. So we said be alert to these in your patient. What else can we do for our patient? What's our plan? We want to also monitor pupillary reactions. Remember, we said you're looking out for those constriction. If the pupils are constricted, then your client possibly is having a herniation. We also want to monitor the client's Glasgow Coma scale. We said 4 points for eyes, 5 for verbal, 6 for motor, and we said 15 is the best score, while 3 is the lowest score. It can never be a 0. And we said score to 3 to 8 indicates severe head trauma, while a score of 15 indicates that the client is alert and oriented. We also want to maintain respiratory function in our clients. Again, positioning, elevate the head of the bed 30 to 45 degrees. Why? It's going to help to promote venous drainage from the brain. So again, you want to remember this on the NCLEX. We also want to avoid neck flexion, coughing, sneezing, and bending forward. We can even support the client in a cervical collar or neck rolls. And we also want to reduce environmental stimuli. As still part of our plan, we want to prevent the Valsalva maneuver. So you want to teach the client to exhale while they are turning or moving in bed. Remember, your Valsalva maneuver is that breathing method that may slow your heart when it's beating too fast. So remember, we already said this client has a very slow heart rate. So we don't want anything that will further slow it down. So you want to teach them to exhale while they are turning or moving in bed. Again, we don't want them straining so much, so we want to administer 2 softeners like our Docusate. We also want to restrict fluids to 1,200 to 1,500 mL per day. And we want to administer medications like our mannitol, which is an osmotic diuretic. It's going to help to reduce fluid volume. We're going to give our dexamethasone, which is our corticosteroid therapy. It's going to help to reduce cerebral edema. And we're also going to give our anti-seizure medications like our phenytoin and our phenobarbital, even our diazepam. Let's quickly look at myocardial infarction. Again, when there's a blockage to any of the coronary vessels, that could result to a cessation of blood flow to that portion of the myocardium. Again, myocardial infarction may be silent or it may go undetected, or it could even be catastrophic, leading to sudden death. As part of our assessment with this client, you can see how the patient is already in pain. So that's one thing you're going to see in this patient. It's going to be chest pain, severe crushing, prolonged substernal pain, and it will be unrelieved by rest or nitroglycerin. They would even tell you it's radiating to one or both arms, to their jaw, their neck, and even their back. Again, for the NCLEX, remember that women may present with atypical symptoms. So the women may not present with, especially elderly women, they may not present with this common chest pain that's radiating to the arms. Rather, they could tell you they are feeling fatigued, or they are feeling short of breath, or they feel like they are having a gastric ulcer pain, or they are having indigestion. So you want to look out for that in women. They may present with atypical symptoms when they are having a myocardial infarction. They could also be nauseous, vomiting, gastric discomfort, indigestion. The client may even go into shock. So again, you can see their systolic blood pressure below 80 millimeters of mercury. Look out for that gray facial color. You can see how the client is looking. Lethargy, cold, diaphoresis, that excessive sweatiness. You can even see peripheral cyanosis. Their heart rate may become very fast, or even become very slow, and their pulse would be weak. We could also see oliguria in this client. We could see dysrhythmias like your heart blocks or even asystole. If we carry out investigations, the ESR will be elevated. We can also test for CKMB, and this is usually the first enzyme to be elevated after a myocardial infarction. So you want to look out for your CKMB in this client. It appears 3 to 6 hours, and it peaks within 18 to 24 hours. Again, remember, your CKMB is the first enzyme to be elevated after a myocardial infarction. We can also look out for our LDH, our troponin, even our myoglobin. The LDH would appear 12 to 24 hours. Your troponin would peak between 4 to 12 hours, and it can even remain elevated for up to 2 to 3 weeks. I mean, your troponin, it peaks in 4 to 12 hours, and it can remain elevated for up to 2 to 3 weeks. And with our myoglobin, it begins to rise within 1 hour, and it peaks in 4 to 6 hours, and it can return to normal in less than 24 hours. Another basic investigation we must carry out, especially in the presence of chest pain, must be to carry out an ECG. Again, what are you looking out for in your ECG? We're looking out for ST segment elevation. Remember, with your ST segment, normally your ST segment should be on the isoelectric line. So this is our ECG. So this should be our ST segment. So this should be our ST segment. But what do you see on your ECG? Your ST segment becomes what? Elevated. So that's the elevation right there. That's the elevation right there. That's what you're looking out for in your clients. If we see this in numerically consecutive leads, maybe V1, V2, V3, are seeing ST segment elevation, that tells you your client is having a possible myocardial infarction. What's our plan for this client? Again, we want to provide thrombolytic therapy. So we're going to administer drugs that are clot busters. They're going to help to dissolve the blood clots that have blocked those arteries or vein. For example, your streptokinase. or our RTPA, your recombinant tissue plasminogen activator. This is going to help to dissolve the thrombus in the coronary artery. Again, we want to give this within 6 hours of onset. You want to give it within 6 hours of onset. We also need to monitor our clients' intake and output. So again, fluid intake at between 2,000 mils daily. Remember, too much fluid may precipitate a congestive heart failure, and too little fluid may result in dehydration. So we want to manage that. Again, we want to put in a Foley catheter if necessary to look out for, to manage our clients' fluid status. Remember, oliguria. If your clients become oliguric, what does it tell you? It tells you there's inadequate renal perfusion. So you want to look out for that. Again, if the urine is concentrated, it also tells you your client is possibly dehydrated. So look out for that. Oliguria tells us or tells me there could be inadequate renal perfusion, while the concentrated urine could indicate dehydration. We also want to carefully monitor the client's IV infusion. We want to, the vein should be kept open in case of emergency IV drugs if we need to give those. We also want to administer medications like our beta blockers, your propranolol. We also want to give morphine sulfate for pain. It also helps to decrease anxiety. We want to give antidysrhythmics like your lidocaine, your verapamil, your sotalol. We would also need to give anticoagulant medications like our heparin and warfarin. So again, heparin is your anticoagulant. You want to manage those therapeutic values. Remember, if your client is on heparin, the therapeutic values of your APTT should range between 60 and 70 seconds, depending on the control value. So again, if I say a value of 100 seconds, that tells me my client has received too much heparin. Again, if he has received too much heparin, then it means he's at risk for bleeding. Remember, you could see it on the NCLEX. The antidote for heparin would be what? If we've given heparin overdose, what would be our antidote? We want to give protamine sulfate. So again, you want to take note of that on the NCLEX. We would also need to administer oxygen to our clients. And as part of our teaching, we want to teach the clients that healing will not be complete for 6 to 8 weeks. He needs to modify his lifestyle, stop smoking, reduce stress, decrease caffeine, modify intake of calories, sodium, and fats. He needs to maintain regular physical activity, maintain his medication schedules. You need to teach them adverse effects of those medications. And we also need to prevent complications in these clients. One major complication we need to avoid in our clients after a myocardial infarction would be dysrhythmias. Remember, this would be abnormal or irregular heartbeats. And these are the most common complication and the most common cause of death after a myocardial infarction. So again, we need to prevent this complication. Again, we also need to prevent shock. For example, your client could go into cardiogenic shock. We need to prevent those. Congestive heart failure. Here, the heart can pump blood well enough to give the body a normal supply. So again, the blood and fluids is going to collect in the lungs and in the pulmonary system and even in the legs over time. So again, we need to prevent all of that because you're going to start seeing symptoms of shortness of breath, fatigue, swollen legs, rapid heartbeat. We're going to see all of that in our clients with congestive heart failure. Again, we also need to prevent another complication, which is rupture of the heart muscle. We need to prevent pulmonary embolism. So again, pulmonary embolism would be a condition in which one or more arteries in the lungs become blocked by a blood clot. Again, what are you going to see if your client develops a pulmonary embolism? A clot is in the lung, so obviously the symptoms are going to be related to breathing. So you're going to see shortness of breath. You're going to see cough. You're going to see chest pain. And again, it could also lead to a recurrent myocardial infarction. Let's quickly look at seizures. So again, like I mentioned, we won't take questions until after the class. So please, if you have questions, you can write them down and we'll run through them after the class. So again, with seizures, this would be episodes of abnormal motor, sensory, autonomic, or psychic activity due to abnormal discharge from brain cells. So again, these seizures could be caused by maybe epilepsy, or fever, especially in children. Head injury could also cause seizures, an infection of the brain or the central nervous system, or a brain tumor, or even a stroke or drug withdrawal. Any of these can cause your clients to go into seizures. So what are the types of seizures? We could have a generalized seizure or a tonic-clonic seizure. So again, tonic seizures would cause a stiffening of muscles. So the tonicity, the tonic seizures is going to cause stiffening of the muscles, while the clonic seizures is going to cause jerking, or you're going to see them twitching. So again, we said with tonic seizures, you're going to see stiffening. So they become very stiff, while with the clonic phase, you'll notice this jerking or twitching phase. Again, clients may have bowel or bladder incontinence. And in the post-ictal phase after the seizure, they could fall asleep and they could be hard to arouse. We could also have absence seizures. This is usually seen in children. They have this staring spell or staring spell with lip smacking and chewing. We could also have myoclonic seizures, usually see onset in children, and they have this brief muscular contraction that involves one or more limbs or the trunks. What should we do during a seizure? What's your role? What do you need to know about seizures for the NCLEX? We need to protect from injury. So you want to raise the side rails or maybe ease the client to the floor and protect them from injury. You also want to use padded side rails according to your agency policy. You want to loosen restrictive clothing. And again, don't try to restrain the client when he's having the seizure. Do not restrain the client. Do not try to insert a bite plug or a padded tongue blade or an oral airway. Do not insert any of this. So don't insert a tongue blade, don't insert an oral airway while they're having a seizure. And again, the client may be flailing their arms, so you want to protect yourself so that you don't get injured while the client is having a seizure. We'll need to place the client on the side with the head flexed. You also want to monitor the onset, duration, and pattern of the seizures. Remember, we said the tonic seizures are going to cause stiffening, clonic seizures are going to cause jerking or twitching. We would also need to administer medications for status epilepticus. Remember, status epilepticus would be the clients having maybe one or more seizures within a 5-minute period, and they don't return to normal between them. So it's almost like continuous. So you have one or more seizures within a 5-minute period without return to normal. So that would be your status epilepticus. So we'll need to administer medications like your diazepam, your lorazepam, your midazolam. So these are going to be used to manage our status epilepticus. So what would be our plan after seizures? So again, we want to position on side to prevent aspiration. We want to reduce environmental stimuli. We want to provide oxygen and suction equipment if needed. We want to reorient the clients when they become conscious. We want to provide description of the seizures in our records. You know, how did the seizure start? What were the types of body movement? What were the areas of the bodies involved? Okay, you want to take note of any presence of involuntary motor activities like lip smacking. Was there incontinence? What was the duration of each phase? Okay, you want to take note if the client was unconscious during the seizures or if there was paralysis after the seizures. Again, what are the actions after the seizures? Was there confusion? Did he sleep off? Look at the speech. So now let's look at how we can prevent seizures in our clients. What do we need to know for the NCLEX? Again, we'll need to administer anticonvulsant medications like our phenytoin and our phenobarbital. You want to remember for the NCLEX that the therapeutic range for our serum phenytoin level should be 10 to 20 micrograms per mil. So again, we want to maintain this therapeutic level. So we said we want to maintain our client's serum phenytoin level to between 10 to 20 microgram per mil. So a level below this range tells you that the client is not receiving sufficient medication. It means it's at risk for seizure activity. So we may need to adjust the dose upwards. And you also want to remember with phenytoin that it can cause what we call gingival hyperplasia. So again, your phenytoin can cause gingival hyperplasia. This is a side effect of our phenytoin. It's also called dilantil. So again, you're going to see this drug is going to increase the risk for periodontal disease, tooth decay, oral infection. So when it's observed, please do not discontinue the drug suddenly. Teach your clients to avoid alcohol. Encourage them to carry out good oral hygiene, and they need to carry a medical identification. So again, we want to tell them not to discontinue the medications, suddenly avoid alcohol, practice good oral hygiene, and carry a medical identification bracelet. Again, we need to teach the client to avoid seizure triggers like alcoholic beverages, stress, caffeine, fever. We also need to teach the client or give them complementary or alternative therapies like your ketogenic diet. This has been shown to prevent seizures. So again, you want to teach them a diet that is high in fat and low in carbohydrates, and also help to keep the body in a constant state of ketosis. And it is believed that this diet can also help to reduce inflammation in the brain. With shock, shock is a life-threatening condition that occurs when the body is not getting enough blood flow. So here you're going to see sudden reduction of oxygen and nutrients. There's decreased blood volume that's going to cause a reduction in venous return, and it's also going to cause decreased cardiac output. Shock is divided into 4 main types. We could see obstructive shock. So just like the name sounds, something is obstructing the great vessels. So there's a physical obstruction of the great vessels or the heart. It could also be a cardiogenic shock. It's actually a life-threatening condition where the heart suddenly stops pumping enough blood and the rest to the heart and to the rest of the body. So you're going to see decreased cardiac output. So you can see cardiogenic shock in clients with maybe MI or even a heart failure. It could also be classified as a distributive shock. So with distributive shock, there's an abnormal distribution of blood flow, especially in the smallest blood vessels. So you're going to see inadequate vascular tone. It could be neural induced, maybe from insulin shock or from spinal cord injury, or it could be chemical induced, maybe from toxic shock or anaphylaxis, or even a capillary leak in bones. And we can also have hypovolemic shock. Again, this results when you lose a lot of blood, and it can lead to organ failure. So there's loss of fluid from circulation. Again, what are we going to see in our clients who is in shock? So the client is going to experience decreased blood pressure, increased pulse, and then increase in respiration. Again, you can see this is in opposite to your intracranial pressure Cushing's triad. So again, you want to take note of both of them. So with shock, the BP goes down, pulse and respiration go up. With increased intracranial pressure, BP goes up, pulse and respiration go down. What are other symptoms we're going to see in this client? The client is going to be cold. The skin is going to be clammy. There will be cyanosis. If you check the capillary refill, it's going to be greater than 3 seconds. You would also notice restlessness, decreased alertness. There will be anxiety. There will be weakness. You could also see, okay, so we said there will be weakness, there will be tachycardia. The client could go into metabolic acidosis. So again, they will be accumulating too much acid in the body. We could also see oliguria. There will be increase in urine specific gravity. So again, high specific gravity suggests that the concentration of urine is too high. So again, look out for high and dry, because that could be a sign of dehydration. So if your specific gravity is high, then the client is dehydrated. So remember, high and dry. And again, we could also see increased muscle weakness in this client. What would be our plan for these clients? What would be our plan for these clients in shock? We want to maintain adequate oxygenation and tissue perfusion. If necessary, we need to ensure ventilation. We want to maintain systolic blood pressure greater than 90 millimeters of mercury. So remember that for shock, you want to maintain a systolic blood pressure greater than 90 millimeters of mercury. We said the client could be in metabolic acidosis, so you want to treat that acidosis, maybe with, we can give sodium bicarbonate. We want to maintain a patent airway. We might need to put in an indwelling catheter. We want to check hourly outputs. Remember, if you have a urine output of less than 30 mils per hour, that's a serious cause for concern. So look out for the urine output. If we have a urine output of less than 30 mils per hour, it's a serious cause for concern. We also want to assess CVP, want to maintain warm body temperature, so you can see how the client has been covered in a thermal blanket, the feet have been raised up. We can also give crystalloids like our normal saline, and we can also give our colloids like our ETA starch. So this would all be to help to increase the client's circulatory volume. With medications, if the client is in a septic shock, we want to give antibiotics immediately. So remember, with antibiotics, blood, urine, sputum drainage must be sent for culture and sensitivity before we start our antibiotics. We can also give medications to maintain adequate urine output, like our mannitol, our furosemide. We can also give low-dose corticosteroids, especially if the client is in a septic shock. Remember, it could cause confusion. That's why we want to give low-dose corticosteroids. And the last topic we'll look at before we call it a day would be our spinal cord injury. Again, spinal cord injury results to loss of motor and sensory function below the level of injury. So let's look at levels of spinal nerves. If you're having trouble remembering the regions of the spine and how many vertebrae in each, all you need to do is remember breakfast at 8, lunch at 12, dinner at 5. So again, I know that breakfast at 8 tells me that there's 8 cervical vertebrae. Again, the cervical spines control the diaphragm, the chest wall muscles, the arms, and the shoulders. So again, remember that your cervical spines control the diaphragm, the chest wall muscles, the arms, and the shoulders. So if you have injuries greater than C4, it's going to result to paralysis of respiratory muscles and all 4 extremities. So if I have injury greater than my C4, it's going to result to paralysis of respiratory muscles. So look out for that respiratory problem in that patient. Your lunch at 12 tells me thoracic. There are 12 of them, and it controls upper body and also GIT function. My lumbar is 5, my sacral is 5. They control lower body and bowel and bladder. So again, following a spinal cord injury, patients may experience temporary reduction or even loss of reflexes. That's known as a spinal shock. So after a spinal cord injury, look out for that spinal shock, that temporary reduction or loss of reflexes. So again, how would you know your patient has gone into spinal shock? You would notice flaccid paralysis of skeletal muscles. You could also see complete loss of all sensation. There will be decreased pulses. You would notice the bradycardia in this patient. There would also be suppression of somatic reflexes, suppression of visceral reflexes, so that pain, touch, and temperature reflexes would all be lost or suppressed. The client could also have postural hypotension. There could also be circulatory problems like edema, and you would also notice alterations in normal thermoregulations. What's our plan for a client in spinal cord injury? Again, we want to assess airway, breathing, circulation. We want to stabilize vital signs. We want to do a head-to-toe assessment. We also want to assess and immobilize the cervical spine, maybe with a skeletal traction or even a surgical stabilization. We might need to administer our antispasmodics and even our steroid therapy. So your antispasmodics could be your baclofen or our diazepam. We'll need to place the client on hyperbaric oxygen therapy. Remember, hyperbaric oxygen therapy is going to give oxygen at 100%, and this is going to help to reduce secondary damage in spinal cord injury. So that's our hyperbaric oxygen there. If we need to move this client, we want to move him by log rolling, or we want to use turning frames when we are moving our client. We want to provide good skin care, provide emotional and family support. We also want to ensure adequate nutrition in this client. Again, bladder and bowel training is key. Bladder and bowel training is key. If we need to catheterize this patient, we'll need to carry out catheterization. We also need to prevent complications of autonomic hyperreflexia. Now, let's talk about autonomic hyperreflexia before we call it a day. Again, this would be a syndrome where there's a sudden onset of excessively high blood pressure. It's a neurological emergency, and it must be treated immediately to prevent a hypertensive stroke. Autonomic dysreflexia is a syndrome in which there's a sudden onset of excessively high blood pressure. And again, we said it's a neurological emergency and must be treated immediately. If not, your client will go into a hypertensive stroke. Again, you can also see clients who have had spinal shock after it has subsided. You can see them going to autonomic dysreflexia. What can cause your client to go into autonomic dysreflexia? One of them would be a full bladder or a urinary tract infection, a bowel distension or fecal impaction, or if your client is constipated. Pressure areas can also cause your client to go into autonomic hyperreflexia. Your clients in restrictive clothing could also go into autonomic dysreflexia. Stimulations of pain receptors in the skin could also cause the client to go into autonomic dysreflexia. What are the symptoms we are going to see? The blood pressure is going to be increased. Remember, we said we are going to see that excessively high, severe, and rapid increase in the blood pressure. Their face will be flushed. They will have this pounding headache. Their neck veins will be distended. Their heart rate is going to slow, so you're going to see that bradycardia. You would notice profuse sweating or excessive diaphoresis, especially of the forehead. You would also notice piloerection in this client, or what we call goose flesh. In terms of our management for this client, in terms of our plan, we want to place the client in a sitting position. Again, you can see this is written in red. So you want to place the client in a sitting position before you do any other thing. Place him in a sitting position, and then we can go ahead catheterizing him or irrigating an existing catheter in case maybe it's as a result of an obstruction to the catheter or maybe a full bladder. And then we can check for the rectum for any fecal mass. Remember, if you can initiate a daily bowel program, that would help to eliminate this trigger. And finally, we can give our client hydralazine, and this will be this would help to reduce that excessive blood pressure.